Good evening, ladies and gentlemen. You are all most welcome to the Neurotorium Educational Series, which is a peer-led training intended to enhance the knowledge of neuroscience among psychiatrists and psychiatry trainees and other trainees, medical trainees in Uganda. So this week, for those who were there with us yesterday, we started on substance use disorders and other addictions. And our presenter is already on the call. You're almost welcome. I thank our principal investigator, Dr. Mwesiga, for also being present and for his support and leadership. I thank you all who joined in yesterday up to the end of the session. Thank you, and please continue to be part of the session. Tell us where you have some ideas to make this better. Dr. Mugume is already around. We had agreed that we start at exactly 7, since the content is a lot, with the number of people that will be there. And maybe our principal investigator can say hello, and then Dr. Mugume takes us from there, looking at the neurobiology of substance use disorders. Thank you very much.
It seems Dr. Mwesiga is not on the call yet.
All right, so I think at whichever point he comes, sorry, I thought I had seen his name. At whichever point he comes, I think he can always give his remarks. We can go ahead and start the presentation so that we have some time for questions at the end. Is that okay?
Dr. Moses, can you allow me to share?
My name is Raymond Gume, and it's good to be with you again. Still trying to see how you... Can you see the slides? If someone can confirm that, that would be nice.
Yes, please.
Raymond, kindly put them in presentation mode.
Okay, thank you, Raphael. So as a recap from yesterday, we also said that addiction is characterized by compulsion to seek or take the substance or engage in a behavior. And in addition to that, you have loss of control relating to that substance or behavior. And we also looked at the different types of addiction, where we looked at the substance use addiction and then the behavior addiction, like gambling, where you have repetitive pattern of use that clinically and significantly affects your life. And then commonly, we also said that addiction and dependence are interchangeably used, but as of DSM-3, that was in the 1980s, that's why we used to have the issue of dependency, substance dependency, but that after that confusion, DSM-5 kind of clarified that. And we also said that once an individual begins to use a substance, they usually start off as a choice because either it gives them the way they are feeling, it makes them relax from their anxiety, and then once that is settled, it kind of gets them into that seeking behavior. And sometimes they will take it because they want to negate the dysphoric state that comes with absence of the drug, or they are seeking for it to take it because then there is discomfort of the side effects that come with the cessation of the drug. We also said that the diagnosis is with the DSM-5 and ICD-11, looking at the 11 substances that are categorized differently, and that there are also many scales and questionnaires that have been developed to help in diagnosis and also follow-up of our clients. To take us through again, today we're talking about neurobiology, and it's important to again keep in mind that these are psychoactive substances, so they have an effect on the brain, and so they will affect the mood, thoughts, sensory perception, and the behavior. Let's dig a little bit into the neurochemistry. So we have neurotransmitters in the brain, and why we are talking about it, it's because they are very relevant in the topic of addiction. We have glutamate, which is the principal excitatory neurotransmitter in the CNS, and it's found in every part of the brain. And once it is introduced into the synapse, usually it is either metabolized into glutamine or resupplied into the neuron terminals by transporters in the glial cells. Then we talk about GABA. GABA is the main inhibitory neurotransmitter in the CNS. For it is really inhibitory, and it works on the GABAergic neurons, and it's also found everywhere in the brain. GABA is removed from the synapses by specific transporters that up to now we haven't really got to know which one is which, but at least we know that it is usually removed as building from Dr. Katama's presentation about synapses and neurotransmitters. And then we have serotonin, which is found throughout the body. It is in high concentration in the CNS, but we have also, it has also been documented to be on the platelets. It is also in the certain cells of the GIT. And these serotonergic neurons usually project throughout the brain, and they originate from the raphe nucleus, which is in the brain stem. And then we have the dopamine. Dopamine usually is secreted from the nucleus accumbens, and it is very essential. And when we talk about addiction, there's no way you can talk about addiction minus dopamine being on your tongue. So how it acts is that it how it works is that, members, can you still see my slide? Because I can't see it myself.
We can see and hear you very well, Dr. Raymond.
Yeah. Okay. Okay. I'm still getting used to these things. So dopamine, like I said, it is the main neurotransmitter that has been implicated in addiction because one, it is involved in our motivation, the need to do something, that urge where you feel like you have a purpose, you have meaning, in the reward, that accelerating effect that you usually get after you've won, or maybe like how Arsenal won yesterday, and then they reinforce it, the need to want to do the same thing. And it also plays an essential role in the basal ganglia, where it is important in movement control and coordination. And then we have these receptors. Dopamine works under the second messenger system, the AMP, which is the adenine, I forget the full name, and then once the cyclic AMP is activated, then many biochemical processes usually happen. We need to know the classes of drugs. I know that probably yesterday I talked about them, but not in full amount. We have the stimulants, we have the opioids, the depressants, and the hallucinogens. The stimulants, we have cocaine, and on the market so far, or in Uganda, we already have this cocaine in its impure forms. We have its street name usually called coke. In Uganda, it's called obungo bwebeyi. We have amphetamine, we have methamphetamine, and then we have nicotine and caffeine. Caffeine, really, we have used it in coffee for a very long time. It is now in our soft drinks. Nicotine usually is, as we shall see, it is more with cigarettes, really, including the vapes that people use. We have also the opioids, also known as narcotics. Usually these are highly regulated. To get it from the pharmacy, you need really to have a prescription and a basic reason or why you should need them. We have heroin, morphine, opium, Demerol. We also have synthetic opioids, the fentanyls, tramadol, among others. Then we have depressants. The number one that we are all aware of is alcohol. We have barbiturates, we have benzodiazepines, including such as clonazepam, alloprazolam, Diazepam is the most known. And then we have the GHB, which is the gamma hydroxybutyrate as well. Then the hallucinogens, we have heard of LSD, which is the then we have the mushrooms, we have the ecstasy, or MDMA, and then the mescaline, peyote. How are these drugs? How do these drugs get into our bodies? How do people usually use these drugs? We have swallowing, orally, you have snorting, we have smoking, inhaling fumes, IM injections, subcutaneous injections, IV injections, topical and sublingual. Why am I talking about these routes? So before we get into the deep neurobiology of how the drug gets into the receptor, we need first to know how they get there. And then we also have to keep in mind our pharmacokinetics, which is how the drug really is taken in, absorbed, metabolized, and then excreted. And then the opposite of it, which is, I forget it again, but which is really looking at the effect of how the drug then works on the body, right? So that's why we want to first understand the routes of administration. And then now in addiction, depending on how fast the drug gets into the brain, the effects are usually exacerbated as compared to the low onset drugs. The ones that you swallow usually take a lot of time before they get to the brain, because then they have to pass through the the blood-brain barrier to get into the system. But then when you use drugs like the drugs that you give IV, sublingual, or even smoking, those ones get into the system way faster, and so they are more available to start their effects on the brain level, which means usually their effects are usually more exacerbated. But again, I'm going to delve deep into that. So this is really the speed of action. Once you smoke, it takes about 7 to 10 seconds to experience the effects. If you do IV injecting, 15 to 30 seconds is all you need for the effects to come in. And injecting into the muscle under the skin, it takes 3 to 5 minutes. So you can see the variation in the timing that you need. When you use the mucous membrane absorption like snorting or rectal, you need again 3 to 5. It is more like an extended release. Swallowing, so you see it takes more longer. It takes 20 to 30 minutes for it to start action. So those that are absorbed through the skin, usually they work slowly over a long period of time. You have heard of like fentanyl patches, which is used usually in surgery, and I know that most people have maybe used it. I also used it when I was a medical intern, but I did not know better. But now, and the reason is that there used to be a saying that maybe fentanyl, when you use it subcutaneously, it is not addictive, but studies are starting to refute that. Now let's go into what we call the dopamine system and addiction and how that goes in. So like I said, what will stand out in this whole discussion is that dopamine. It's what has been implicated to be the reason why people get addicted, and we shall see how that comes about. Important to note is this reward pathway. What you see, let me try to use some technology here, the laser pointer. So these are really neurons, right? They are coming from one place to another, right? So we have here, this is where we have our nucleus accumbens. The nucleus accumbens is here. Here you have the amygdala and the hippocampus. You have the striatum, you have the substantia nigra, and then the hippocampus, which is literally here. The hippocampus is important for memory. And then as you can see, the neurons that project on the amygdala to the hippocampus, and then they also project on the nucleus accumbens, which is the main source of what? Of dopamine. Then some neurons that come from these structures also go into the frontal cortex, and we know that the frontal cortex is very important for executive function. What is included in the executive function? How you think, reading social cues, being able to make decisions. Then there is the go and no go task. Then the stop signal task, where you, maybe let's say you've started an activity and then you can be able to make a decision and say, no, this one I can't continue with it, right? That is the stop signal, the stop signal what? The stop signal. And then the go is when you gauge and say, can I approach that lady? And I will keep bringing this back because I know that either we have experienced it or we know a friend who has experienced it. Yeah, that when they are sober, they have the no go. I can't go there. But then once they drink like one bottle, they are still in the no go zone. But then after like 3 bottles, they go. So the executive, the frontal cortex is really, really important because, again, it inhibits us in one way or the other. And then we have the striatum, which is also implicated in addiction, and we shall see what these usually do or what is their role in addiction. But important to note is that we need to remember that when we are talking about addiction, we are talking about what we call pathways. Because in the brain, you know that we have neurons, and so I'm going to take some time to really explain more about these neurons. We know that so the substantia nigra, just to correct, is where we actually have the dopamine coming in, but the nucleus accumbens has also been implicated. We have the ventral tegmental area, which is also very important, as we shall see in the coming slides. Why am I saying they're very important? The striatum, like I said, it is made of 2 things. It has the caudate and has the putamen. And it is subdivided into the dorsal striatum and the ventral striatum. The dorsal striatum, which is the dorsal is this one, and then no, this is the ventral, this is the dorsal. Yeah. So the dorsal is usually implicated in maintaining addictions. And we said that you can be addicted to anything, including your internet, including shopping, eating, and not only substances and alcohol, but anything else. You can be addicted to work so long as it significantly affects the other areas of your life. And then we have the ventral striatum, which is really about gaining, which is about learning. And it has been implicated in impulsivity and compulsivity. So that's why I want us to understand these areas, the striatum. And then we'll look at the mesocortical. The mesocortical is this area here, but we shall see it properly when we look at the pathways of the dopamine. And for it, of course, it is very important in decision making and inhibition as well. It is very, very important. So with that, let me go to this dopamine pathway. So I know that all throughout you've always known that there are only 4 pathways of dopamine, but I got to know that we actually have 8 pathways, and I will just peruse through, but I will intentionally look at these 4. Why? Because again, it is very important that we get to know what they are or what they do in the issue of addiction. So one of them is what we call the mesocortical pathway. And I've said that the mesocortical area just usually deals with our perception of how we see things, we see the world around us, and also we internalize things inside us. Then cognition is really about thinking, and then social behavior. That's why you know that when you reach people, you either handshake or you bow down or you kneel, because again, you have your mesocortical area looking nice. And so that is when dopamine is released in those areas, that is what you're dealing with. Then you have so what it means is that it is from the ventral. So this area here is called the VTA, which is the ventrotegmental area, and it is usually from this area, and it goes to the nucleus accumbens, which is around here, and but also it gives off to the amygdala, which was around here, and then the hippocampus, which was also around here, as you remember from the last diagram. Let me just go back just to make sure that we understand that, right? So this is the pathway that we are talking about, is that you're coming from the ventrotegmental, the VTA, which is this one, right? So the VTA to the nucleus accumbens, right? It goes to the amygdala, which should be around here. It is usually not very far. Then it goes to the hippocampus, and then the prefrontal cortex, as you can see. So that is what we call the mesocortical, right? Are we together? Then we have the mesolimbic pathway. Here, the limbic system has always been about emotions, right? And memory. So how you feel, usually you will, if someone has gotten you angry, right? Even if they say sorry, your emotion, depending on how that person made you feel, your emotion will be that they made you angry. So the memory, because the hippocampus, again, I told you the hippocampus is about memory. Your emotion is associated with the emotion. What I'm saying is that the emotion gets associated with the memory of how that person made you feel. Okay, so the mesolimbic pathway is what it is about. It's about emotion and memory, then pleasurable sensations, depending on if you felt sad, angry, happy. So which means if you take a drug, depending, let's say you were sad, and then you take alcohol, it makes you happy. That mesolimbic pathway gets into play, where you get euphoria, and then the effects of addictive substances also come in. So usually you have that, why you hear people saying, hey, I'm hallucinating, I'm illusioned. You're literally misinterpreting the stimuli. That is where the pathway that is coming into play. Okay. And that's important to talk about. Then we have the tuberoinfundibular pathway. This is usually this pathway usually inhibits prolactin, and I know that as we shall see later, maybe in schizophrenia, the drugs that usually kind of interfere with this pathway, and then you see people having big breasts and as a side effect. Okay, then we have the nigrostriatal pathway, which one here you're controlling movement, the final movement or initiation of movement. You've seen in people that when they drink alcohol, usually walking becomes in a zigzag form, okay? So you need to understand that the nigrostriatal pathway has been compromised there, even when it means, and if they drink for a long period of time, they cannot even write properly, they cannot do the finger, nose tapping, among others. So that is very important to get in mind. So we get to the brain changes that result from chronic substance use. We need to keep referring back that addiction, again, it starts from a choice until it develops into a habit, okay? Now, I've talked about, this is the nucleus accumbens, okay? That is here, this is the amygdala, this is the hippocampus, you have the prefrontal cortex, you have the anterior cingulate gyrus, you have the orbitofrontal cortex, and again, right? So where you see green in this map, it means go. I've told you about the go and the no-go zone, the no-go signals, okay? So what happens when you drink alcohol or you abuse drugs? Let me not use only alcohol, but when you use drugs of abuse, right? Usually they will again use the dopamine as using the pathways that I've talked about, okay? And once from the ventrotegmental area, right? Either if the mesocortical, especially mesocortical, it usually, again, it will affect the prefrontal cortex and the anterior cingulate gyrus, which are very responsible for your executive functioning, okay? And that in turn also affects the orbitofrontal cortex, okay? And so what does that mean for anyone who is on this slide or in this lecture? It means that we need to always have the science at the back of which area is being affected. And we shall see how later, maybe tomorrow, how these drugs can come in to help us with this. So the amygdala and the hippocampus, emotion and memory. Then I've told about you that the whole of this is the prefrontal cortex really, but then we have different parts for different things, as we shall see. And then in instances where you have used alcohol for a very long time, usually the disinhibition, because you first take and then you're disinhibited. When you're disinhibited, that's when you go and talk to the girl, that's when you go and do risky behavior. Sometimes if you are going to have sex, you will forget that you have to use condoms, among others. So there will be changes that include play in terms of cognitive control, the thinking control. Your motivation reduces over a long time again because the dopamine receptors either reduce or there's not enough dopamine. And then learning and memory also comes in because again you're having the hippocampus in play, as well as the hippocampus is in play, but also the prefrontal cortex is also in play. So now that we have taken the drug, we have known how fast they can work, and that we have seen which the dopamine and the reward pathway, we now go at the brain level. And what are we looking at? We are now going at almost at the level of the synapse, okay? In the brain, we have inotropic receptors, and then we also have metabotropic receptors, and all those things work very differently, as I'm going to explain some of those receptors, and we shall talk about the second messenger systems like the G-coupled protein receptors, and then the ones that ionotropic. It means that what they do is that they allow ions to go through. Okay, once the drug or the neurotransmitter touches, they will allow the ions to go through, either calcium, sodium, potassium, chloride. That is what it means by ionotropic. Okay, and they're usually very fast. Once the ion goes in, they're usually very fast, and you will get rewards or you will get effects there and then. Okay, what are the examples of the drugs that would give us that? We have nicotine, we have benzodiazepines, ethanol, phencyclidine, barbiturates, among the drugs that work at the work with the ionotropic mechanisms. Okay, and how do they work this? Once they attach, usually there will be like how the lock and key, right? There will be a site, right? A site of where they attach, and then they will modify the shape of the channel protein, increasing the flow of the ions, which then later gets into the depolarization of the neurons, and then the rest is history. Then when we look at the metabotropic mechanisms, usually these ones are very slow because then they have to work through second messenger systems. An example is the opioids, the cannabinoids, hallucinogens, phencyclidine. For them, once they attach on the receptor, okay, the receptor is this one here. Once they attach, they activate the second messenger system. Let's say dopamine attaches, usually the cyclic AMP is the one that will come into action. And it's important to know that once the second messenger system comes in, then it affects the cellular processes that later end up releasing later affect the protein channels in the membrane, allowing in these electrolytes. Okay, no, not electrolytes, but ions. Okay, so again, this will affect your rewarding system. It will affect your control. It will affect your cognitive function. It will affect your seeking behavior and how you feel at the end of the day. Okay. Now, the pharmacological targets of some of the classes of the drugs that we looked earlier, when we talk about nicotine, nicotine really works on the nicotine acetylcholine receptors, and the effect is that it would increase dopamine levels within the synapse. And although they say it is either direct or indirectly, what is so far known is that it seems to be an indirect way of increasing dopamine release in the nucleus accumbens. The stimulants like the cocaine, amphetamines, for them, they inhibit the dopamine transporter and then the vescomonoamine transporter 2s. Those ones are usually responsible for getting the dopamine from the synapse out into the vesicles to be repackaged. Once you inhibit that, it means that once you inhibit those transporters, it means that you have a lot of dopamine in saturation, and so then the effects will be felt: the euphoria, the excitement, the lack of judgment comes in, and the rest is history again. Also, one of the other drugs that we talked about is the MDMA, which is MDMA is in food is the methylene dioxymethamphetamine. It also enhances the net release of monoamines, and we talked about monoamines including dopamine, serotonin, among others. The benzodiazepines work on the subunit of GABA A receptors, and they are sedatives. You remember, they are sedatives. So once you enhance or you moderate the action of GABA, then usually you will have like your mood low, you'll be quiet. Although at the beginning, usually there's that disinhibition, you're talkative, but the more you drink over time, your GABA kind of gets into saturation. So benzodiazepines, barbiturates all work at the GABA receptor. And GABA receptor, as we shall look at, as we shall see later, it has those the metabotropic mechanism. So it's usually slow. Okay, and again, this is as we shall see later. I'm going to explain that later. Alcohol, of course, again works on the GABA receptors, increasing dopamine. Opioids work on the new opioid receptors, and we shall understand the endogenous opioid system. Then cannabis, especially the psychoactive type, which is the tetrahydrocannabinoid, works on both the glutamate and the GABA receptors, increasing the dopamine, and they work via the CB1 signaling in the prefrontal cortex and the ventral hippocampus. And then hallucinogens, the LSD, the mushrooms, those ones also work on serotonin receptors, especially serotonin 2A and then 2C receptors, which 2A increases dopamine, 2C reduces. So depending on which one you have taken, the effects will be different. So how does dopamine cause these changes in addiction? One of the theories that we know is that reduced dopamine receptor numbers. There are usually fewer dopamine receptors in the brain for some individuals who have chronically used these substances. But that alone has not been able, since this research has been going on since the 1948s, right? To understand again addiction and its problem and its consequences. Dopamine has been the theory that we have used, but now literature is saying that dopamine alone might not be enough to explain the consequences that we get, and also to explain why sometimes you give drugs in this substance use problems, and you get like effects, but then they are not long-term, okay? So that is what a disclaimer I wanted to make. The dopamine receptors that are usually implicated and are usually very low is the dopamine receptor 2 and D3 receptors have usually been reduced in people who use stimulant and alcohol use disorder. Then also there is an implication of reduced dopamine. Apart from you having reduced dopamine receptors, you also have reduced dopamine release. And this is usually in the effect of what? of chronic use. So you will find that these people usually are snobby, they're isolated, they are sad, especially when they are not drinking what? Alcohol. So the alcohol, again, kind of stimulates them a little bit to feel some happiness that is momentary. So let's look at alcohol and the brain, okay? So again, one of the things that we need to understand is that we have used animal models for a very long time to understand addiction. But there is a call now that maybe we should actually start examining brains or using brains or either post-mortem to understand, because there are some differences between animal models and human beings that are still not very clear. So to understand this, I will come back to this, but let me first go to this, and then I will go back to the slide I have just left. So interaction of alcohol with the brain reward circuitry is actually through the, we have we have the prefrontal cortex, we have the actuate nucleus, and then we have the ventrotegmental area. What you can see here is that there is synapsing, okay, of these neurons within the ventrotegmental area, okay, as you can see. Here, through the opioid or the opioid receptors, the endogenous opioid system, right? It does synapse with the GABAergic neuron in the ventrotegmental area. What does that mean? And alcohol affects that system, okay? Where it so when you take alcohol, it will activate the opioid system, and then the opioid system, of course, will end up at the new receptor. You end up releasing some dopamine, and that dopamine comes and synapses with postsynaptically. It's synapses with the neuron of the GABA neuron. And then that causes this, will cause disinhibition at the beginning, but then later over time, that might start to, it will block it. Okay, let me just again rephrase this. When you take alcohol, it does activate the opioid, the endogenous opioid system. And then what happened is that at this level, also alcohol affects this system, because again, I've said it works on the GABA receptors, GABA A to be specific. Once you activate the GABA, it means GABA will go on to inhibit you in your executive function, because you have said that it is the most inhibitory neurotransmitter within the brain. And once that happens, it has an effect on either in the mesolimbic or in the mesocortical, okay? But this is what we are saying here, that alcohol will enhance that GABA release, and then it blocks that presynaptic GABA B receptors through the actions of GABA A. So you have GABA A and GABA B neurons. So GABA A, usually, if the effects are there, it will counteract the GABA B effects. So that's what we are talking about. And then this has an effect on the dopamine. We said you either reduce the dopamine to have addiction coming in, or you reduce the receptors. So once you reduce this dopamine most times, then it has an effect on, it has an effect in the long run in how the person really interacts with the environment. Or to make it more clearer is that alcohol really does not only interact with only the dopamine, it also interacts with the serotonin system, the adrenergic system. But what is again current, or what we know for now, is that the dopamine is the one that has been talked about more extensively. And what that means for us as those who are attending is that then we need to find more reasons as to why maybe to understand why maybe if you give benzodiazepines in alcohol withdrawal, that helps. Or why do we find that some drugs, maybe like naltrexone, naloxone, maybe might not work? And again, it is to understand how alcohol affects this whole system. This is really at that level, at the brain cell level. So this is what I'm exactly saying, that once you drink alcohol, it usually activates the what? The opioid system, or the opioid system, and in that opioid system, you have release of those endogenous opioids, okay, where endorphin is one of them. Endorphin is one of them, which activates the receptors, and then you have release of dopamine. And that dopamine, depending on which pathway that has been affected, if it is the mesocortical, mesolimbic, nigrostriatal pathway, you will have either the reward coming in. Reward is how you feel, how you're feeling, how happy you feel, where you're saying, buy more bottles, buy more bottles. That is the reward. Then the reinforcement is that maybe every evening you find yourself, you have to go and drink a bottle, but over a long time, you cannot work without alcohol. And we talked about that dependency that is physical and psychological. And then in the long run, because the system has been vicious, you have the craving that comes in. And again, it's because we have stimulation and release of dopamine from cells in the VTEA, okay? So this is what I'm literally talking about, that it activates the endogenous system. The mu opioid receptor is activated, releasing the dopamine that then goes on to affect the different parts that are responsible for executive functioning, for reward, for reinforcement, among others. And in the long run, you find that the person can really not control it. So it becomes that chronic relapsing medical condition that we talked about. Okay, so what are some of these effects that we need to keep in mind? Is that this just was a study. We have started doing functional MRIs, which again are trying to understand that the dopamine receptors, if when they're reduced, the D2, D3 being reduced, or the dopamine levels. But what is known is that, so far what we can tell from this slide is that people who have been intoxicated, really, usually they have that risk-taking behavior, the impulsive, and I've mentioned, and this is the go and no-go task and the stop signal task. Because again, the striatum, the dorsal, and the ventral are working in opposite direction. I talked about that the ventral striatum is important for, I said the ventral striatum is very, very important in terms of impulsivity, compulsivity, okay? And then it also has shown, and also it alters the person's emotion and memory or perception, right? Depending, of course, there are also multiple factors. We'll look at the environment, the childhood, the exposure to alcohol, all those factors are coming in, but at the brain level, this is what we can work with, okay? And not everyone who tries a substance will really always go into this downward side of things. Okay, then we look at nicotine. Of course, it has been well documented coming from the Nicotiana tabacum. You can get it, you can sniff it, you can chew it, you can smoke it, and it's highly very addictive, and also one of those that is very challenging in terms of treatment or management. And I said it also works with the nicotine acetylcholine receptors. And what we need to know, of course, we know that the nicotinic receptors, you know that maybe the nicotinic receptors, we have those that are neuromuscular junctions, and then that those that are in the ganglia, and then the adrenomedulla. So if you smoke, usually one of the things that you need to know is that when you smoke, usually the nicotine can go to the adrenal glands, and then you have dopamine being released, among others. But what we need to know with the nicotine, this nicotine acetylcholine receptor, is that it is found in the neocortex, it's found in the hippocampus, the thalamus, the striatum, and then the substantia nigra, which is very, very important, and then the ventral tegmental area, and then also the dorsal nucleus. The dorsal nucleus, remember, it is for serotonin, okay? So That's why these genes, I might not be able to say all of them, but again, there are some that have been implicated. And in instances that we now know is that nicotine also, not at the adrenal glands, it's not dopamine, but adrenaline, which usually causes your heart to race and then maybe causes the blood pressure as well. But in the brain, usually the nicotinic subtype, usually they're very distributed, like I said, and I've mentioned the areas that we have, and it usually affects. It is increasingly saying that it affects usually the GABAergic and serotonergic systems. But again, the real mechanism of how that really happens is still not very clear, according to the reading that I could get, and even from our slides here. And then we go to the cannabis, and then the endogenous cannabinoid system. We need to understand this very well, and we see how cannabis then comes in. So you have two endogenous cannabinoids. So these ones are really produced in the body. You have the 2-arachidonoglycerol, which is from the arachidonic acid, AA, and then you have the N-arachidonylethanolamine, as you can see. And both of them work differently. At the receptor level, at the neuron level, you have what we call the cannabinoid receptors, okay? Cannabinoid 1 and cannabinoid 2. Cannabinoid 1 is the one that has been implicated in opioid use disorder. Cannabinoid 2, on the other hand, has been implicated in the medicinal effects of opioids, okay? And what we also need to know is that
Hello, Dr. Mugume.
yes, please.
We've gone past time by 7 minutes.
Oh,
Maybe
but
I can
I'm
give you 2
concluding.
minutes.
Yeah, 2
Yes,
minutes
let me give you 2
level.
minutes to conclude,
Yeah,
and
yeah,
then we'll
two
have a short
minutes.
one.
Yeah. So what we
Okay.
need to know, to just conclude, the most effect in the marijuana, let's say marijuana, is the tetrahydrocannabinoid. It's the most psychoactive, and then the CBD, which is cannabinoid, is the medicinal aspect of it. And what we know is that THC usually is an agonist on CB1 receptors, downregulating the cyclic AMP. And this will give you the euphoria, it will give you that relaxation, and that you cannot feel pain, right? And the most implicated, what we need to know with weed is at that brain level, there has been more studies that are coming up about cannabis and psychosis. What we now know that of all the drugs that have been implicated, cannabis is more correlated into causing psychosis. It correlated, but it does not cause psychosis, okay? So that is something I need to clarify with this. Given, of course, the odds ratio, although they are various, and also they had to control for other things. Then we also need to, this again, the opioid system, which I've already talked about, but we need to, we look at the agonists and the antagonists at both levels, and treatment, as we shall see later, maybe tomorrow, to actually understand that. But again, they still work in the same way, like I explained from the earlier slides. This is the endogenous opioid system. What we need to know about it is that you have the ecaphalins, the MET and the LU, ecaphalins, which work on the delta receptor, but of importance is the mu receptor and the kappa receptor. And why is that once an endorphin or an opioid attaches on the mu receptor, usually the reward is through the dopamine system. Again, the reward is high, the tolerance is high, the mesolimbic dopamine level increases, which then again facilitates this long-term potentiation at the neuron level. But then when you use the kappa receptor, the reverse is true. The reward is reduced, and you reduce the tolerance, you decrease the mesolimbic system, and then you have inhibition of that potentiation that comes with the neuroreceptor. That is very, very important to know in management especially. This is the interaction of the opiates and in the dopaminergic. We say that the opiates for them, again, they work through the glutaminergic neurons, as you can, the glutaminergic and the GABA. So this is the stimulant. The stimulant, once it attaches the GABA, and then of course it affects the nucleus accumbens here. Stimulants will directly increase the dopamine, whereas opiates, they indirectly increase dopamine transmission by inhibiting the GABAergic interneurons in the VTAs, okay? So like what we are saying is that the opiates, once they inhibit the GABA, then the dopamine should be coming in, because then glutamate through the second messenger system, then you have dopamine being released, and then you have the effects. Okay, so that is very important in knowing how the opiates and the work. This is again just to understand management, but we see that using the opioid system, we can actually be able to treat alcohol use disorder, because again, we have seen that alcohol usually activates the opioid endogenous system. Then you have endorphins coming in that activate that, and then you have dopamine being released, and then it affects the reward reinforcing among the other factors. So then we have genetics. Of course, genetics have been implicated. About 40 to 60% of how the person is usually has been, or how they respond to the drug, they will usually be from the genes, what they carry from their parents. But now genome-wide association studies, this is a new field that we are coming across in psychiatry, and they are looking at specific genes. We haven't been successful with finding the exact genes, but that is what we should know, that the genes are coming in. We see now like the brain-derived neurotropic factor coming in, and they say that different gene locations, especially in cigarette smoking, alcohol use, has been associated with the GCKR, but most especially on how the genes code for the aldehyde dehydrogenase enzymes, the alcohol dehydrogenase enzymes. We are still understanding which genes exactly work, but we cannot only focus on this, minus, of course, looking at where the patient has been, their environment, how they have grown up, and exposure, and also access to these drugs. So this is really a new field. At least we have NeuroGap that has gone in. We are still getting the results on how this works. And this is what I was talking about. Of course, ethane is usually by alcohol dehydrogenase, aldehyde dehydrogenase, the genes that really code for this. We are starting to learn which ones would be exactly important, but this does not again explain, like the presence of the alcohol aldehyde dehydrogenase enzyme, or AREL, has been shown to reduce the risk of developing alcohol dependency. But again, therapies are only just coming up with these gene association studies. So to take note is that there are many different drugs of abuse with addictive potential, and that these drugs interact with the neurotransmitter systems in the brain, including the dopamine, opioids, GABA, and serotonin.
Raymond, this is Dr. Mwesiga.
Okay.
So we want to be able to start and stop on time.
Okay.
So I think maybe Dr. Kemi, maybe you can take over one or two questions. If there are any other questions, you can always answer them tomorrow when we start on time. Thank you.
Thank you.
And thank you, Raymond. Thank you, everybody who tuned in today. Everyone who logged on. At some point we were 90. We apologize that we don't have enough time for the questions, but we can have one or two. Is there anybody with a question? You can raise your hand on the Zoom. but also the questions I saw about the resources, getting the PowerPoint, having a recording. This is all available. The Neurotorium resources are available on the website, and we actually encourage all of you to go to the website and see what's there. There's a lot of resources. You can sign up and receive the PowerPoints and all the other material that's there, including videos, updates in research, and so on. I don't see a hand, so I'll just ask again if there's somebody else that has a question. I'm taking that silence to mean that everything was well understood and there are perhaps no questions. Thank you very much for attending. Please come again tomorrow and invite others. It's still Neurotorium resources that we are using, and we shall be finishing up addiction, substance use disorders, the treatment, and finalizing the topic. Thank you very much. See you tomorrow. Thank you. Special thanks to our principal investigator, Dr. Mwesiga, Moses, and the team that are coordinating, and Dr. Mugume for the presentation, which was detailed. We shall use the same link tomorrow to join. Please register. Don't get tired of registering. It helps us with control. Please register and join, and leave the questions that you may have. Thank you and good night.